Hello, everybody. Welcome back to my channel. This is MJ, the coding coach. This is MJ. I am back. I just want to come to you, talk to you today about frequently coded diagnosis and the risk adjustment model. We're actually going to take one of those diagnoses and we're going to break it down. We're going to break it all the way down so you can understand it. So, let's just hop right into the video. As I hop into the video, don't forget to like, to comment, and subscribe if you love this video. Share this video. If you care, then share. If you care about other coders, you want to get the information out, this is some great information for you. Make sure you share this video, whether you share it in your text, share it on your social media, however you want to share it. If this is helpful for you, then it'll be helpful for somebody else as well. So make sure if you care, then share. So again, today's video is going to be about frequently coded diagnosis in the risk adjustment model. And like I said, we'll take one of those diagnoses and we'll break it all the way down. Oh, you see I have my Valentine's Day nails on. Okay, so I have 30 frequently coded diagnoses in the risk adjustment model. 30 frequently coded. So, just running through the list, diabetes is one, angina, whether it's stable or unstable, artificial openings, like if you have a tracheostomy or ileostomy, any kind of artificial openings, AFib, which is atrial fibrillation or aflutter, morbid obesity, heart failure, chronic kidney disease, cerebral vascular disease, or CVA, cerebral vascular accidents, or CVA is like a stroke. So it's the same thing as a stroke, and that's what we'll be talking about today in more detail. Because a lot of coders get confused when it's time to code for strokes. So we'll talk, frequently coded diagnosis, COPD, deep vein thrombosis, dementia, depression, substance abuse, epilepsy, GERD, hepatitis, HIV and AIDS, malnutrition, hypertension, neoplasms, which is cancer, neuropathy, pneumonia, ulcers and wounds, varicose veins, vertebral fractures like osteoporosis, things like that, pulmonary embolism, sepsis, rheumatoid arthritis, and respiratory or respirator and ventilator status. That's the HCC code as well. So those are the most frequently coded diagnoses in the risk adjustment model. And as you see, I've written some very good notes. So this is coming from notes. Let's go. Let's get into it, coders. So, when coding for a CVA, which is a cerebral vascular accident, and that's going to be I-63.9. So if you're coding from your 2021 book, let's see, because I have both. I have the 2021 and the 2022 book that's right here. So if you're coding from your 2021 book, then it's going to be on page, 679. I-69 is going to be on page 679. So when coding for a CVA, you're going to use the active code I-63.9 only when the CVA is occurring and up to discharge. And when I mean up to discharge, if you hear the word discharge, then it must mean that they're in an inpatient setting, inside of the hospital where they have to be discharged. So you're only going to use I-63.9 in an inpatient setting or up into discharge. So if a patient is coming into the doctor's office for a follow-up for their stroke, you're not going to use I-63.9. That's only used when the stroke is occurring. Excuse me. Now, if the patient is coming into the hospital, if the patient is coming into the doctor's office for something else and they're actively having a stroke, then you're going to code the I-63.9. But if they're just coming for a follow-up or anything like that, you are not going to use I-63.9. You're not going to use that. I had you turn to I-69 on page 679, and that's because that has to do with the sequela of a stroke, and we'll get to that later, but I wanted you to go ahead and turn to their page. So again, I'll read this from my notes. When you're coding for a CVA, cerebral vascular accident, which is I-63.9, you're only going to code that if that person is actively having a stroke at that moment. And it's usually only occurring in an inpatient setting. Maybe they went to the emergency room because they had signs of a stroke. And then once they get there, they realize they've had a stroke or having a stroke. That's when you use the I-63.9. Now, after a patient has been discharged for care of a CVA or a stroke, then he or she has a personal history. Personal history. That's when you'll use that personal history code. Z86, Z as in zebra, 86.73. I'll give you a time to turn to your page. Z as in zebra, Z as in zebra, 86.73. That's personal history of a stroke. Now, you're only going to use personal history of a stroke if that person has had a stroke and there's nothing wrong with them. If they had a stroke and there's no limping, there's no weakness on one side, they don't have any eye issues, it's like they've never ever had a stroke before, then you will use history of a stroke because it's history. They had it a long time ago or they had it 3 weeks ago. There's no effects of the stroke, so you have a history of it. However, if the patient has residual deficits from the stroke, if their mouth is droopy, if they're limping, if they have eyesight problems because of the stroke, then you're not going to use history. History of means the disease or the condition is no longer there. It's eradicated, it's eliminated, it's gone. But if the person has drooping, twitching, eye problems, paralysis on one side, that means something about the condition is still lingering. And as you can see from I-69, this category is sequela of cerebral vascular disease. And we all know that sequela means late effect. We know that means something happened as a result of this condition. We also know that sequela has no time limit. A person can have a stroke 30 years ago and still have deficits from this stroke. They may still have a certain limp 30 years later from the stroke. So we wouldn't use the history of code because they're still having problems of this stroke. We'll come from category I-69 and we'll find the sequela effect. Is their memory gone? It's a code for that. Is there speech difficulty or they can't speak at all? Are they paralyzed on one side? Are they blind? All of those things are sequela effects of the stroke, and it'll be found under I-69 category. So common late effects, like I was saying, inability to speak, difficulty speaking, difficulty swallowing, lack of muscle coordination, and weakness on one side of the body. Now, people rarely really get the concept or understand that if someone mentions a cerebral infarction, it's the same thing as a stroke. I can say doctor, I can say physician, I can say lawyer, or I can say attorney, I can say teacher, or I can say educator, I can say cerebral infarction, or I can say stroke. So if you see cerebral infarction, that is a stroke. So what is a cerebral infarction? So it's also called an ischemic stroke. And this occurs as a result of disrupted blood flow to the brain due to problems with the blood vessels that supply it. A lack of adequate blood supply to the brain cells, this deprives them of oxygen and vital nutrients, which can cause part of the brain to die off. That's what a cerebral infarction is. That's what happens when you're having a stroke. So another thing that you need to understand when you're understanding strokes or CVAs, or not just a cerebrovascular accident, but cerebrovascular disease, you have to understand what a TIA is as well. And TIA is a transient ischemic attack. So if you look for the code Z86.73, it'll say personal history of a stroke or personal history of TIA. So what is a TIA? So a transient ischemic attack is a brief episode of neurological dysfunction when it briefly messes with your neurological dysfunction. And it results from an interruption in the blood supply to the brain or the eye. And then sometimes this is a precursor to a stroke, which means if you're having symptoms, if you're having a TIA, then this usually happens before you actually have the stroke. Now, people often ask, what is the difference between a stroke and a TIA? Because as we see, the stroke, this occurs as a result of disrupted blood flow to the brain. And it causes, problems with the blood vessels that supply it. So we also know that a TIA is a brief episode of neurological dysfunction resulting from an interruption in blood supply to the brain. So people often want to know, well, what is the difference? It sounds like it's the same thing. There is a difference between a stroke and a TIA. So a TIA is often called a mini stroke. You see, I love my quotation marks. So a TIA is often called a mini stroke. And it begins just like an ischemic stroke or a cerebral infarction. The difference is that in a TIA, the blockage is temporary and the blood flow returns on its own. And it usually lasts about an hour or so. The symptoms don't usually last that long. Symptoms of a TIA are weakness, numbness, or paralysis in your face. You know how your face is droopy. Your arms or leg, typically on one side. You have slurred speech, difficult understanding others, blindness in one or both eyes, and double vision. So a TIA, that's going to be code G as in girl 45.9. So a person is coming in and the doctor diagnoses them with a TIA. It's going to be G as in girl 45.9. Now, as far as a CVA, a cerebral vascular accident, and in medicine, we use a lot of acronyms or abbreviations for things. Instead of us saying acquired immune deficiency syndrome or human immune virus, we'll say HIV or AIDS. Instead of saying a cerebral vascular accident, we'll say a CVA. Instead of us saying a transient cerebral ischemic attack, we'll say a TIA. So there's a lot of acronyms, and that's why learning your medical terminology is very important too. Medical terminology is the basic foundation of knowing coding, knowing medicine. I also have a $14.99 medical terminology study guide if you need to know medical terminology. For $14.99, there is a study guide. There is a 30-page study guide. There's 4 or 5 other 20-page study guides with also a quiz. And it also helps you to understand and break down medical terminology. So CVA, this is the formation of an area of necrosis or dead tissue in the brain caused by insufficient blood flow. We already said that it causes some brain tissue to die when you have a CVA. It also may be due to occlusion or blockage or stenosis. So if someone says blockage, another word for blockage is occlusion. Another word for stenosis is narrowing. So if you see the word stenosis, it means something is getting narrow. Something is getting narrow. Now, as you can see, I-63.9 is unspecified cerebral infarction. The reason we would use that as a default code, if we don't know what caused the stroke, then we will just use I-63.9 because it's unspecified. We don't know what caused it. However, if there are residual or sequela effects of the stroke, then we will come from the category usually anywhere between I-60 and I-67. Sequela I-69. Now, as you dig more into the I-69 category, you will see there are different causes for a CVA or a cerebral infarction. You'll see there's different causes and there's different codes that you can use. Now, in the 2022 book is on page 681. Remember, in the 2021 book is on page 679. So let me show you something as well. Turn to I-63. Turn to I-63. I-63 in the 2021 book is going to be 676. And I want you guys to start paying attention to the icons that are on the left of the code. You will not be a great coder. You will not understand coding unless you understand your icons, your symbols, what to do. You read your instructional notes. That's how you become a great coder. So if you look at I-63 on page 676 in the 2021 ICD-10 book, then you will see beside that code to the left, there's a fourth icon. The icon says fourth, 4TH, fourth. That lets you know that there are 4 digits that are needed to make this code valid and billable. If you do not add the 4th digit to this number, it's not a valid code. Now, if you scroll on down to I-63.0, that's 4 digits. Is it enough? No. How do you know it's not enough? Because if you look to the left of I-63.0, it'll tell you need a 5th digit, 5TH. You need a 5th digit in order for it to be valid. So pay attention to the number beside the code to make sure it is valid. For whatever reason the residual effect, the residual deficit is, there is essentially a code for it. Whatever the deficit is, memory loss, paralysis, blindness, whatever it is, there is a code under the I-69 category that will fit it. So let's say that the provider did not document the residual deficit. They just said the patient has deficits due to CVA, but they did not specify, well, what kind of deficit? Is a memory deficit? Can they not swallow? Can they not talk? What is the deficit? So sometimes we're in these positions with these companies and we cannot get in touch with the providers. So we have to code as best as possible from the documentation that's provided to us. So if you find yourself reading a medical chart and a person had a CVA, they had residual deficits, but the residual deficits are not documented, then there is a default code. You know, we have default codes in coding. Just like if someone puts on the medical chart that the patient has congestive heart failure, but it doesn't specify if it's right heart failure, if it's left heart failure, if it's systolic, is it diastolic. So we'll use a default code I-50.9, which is congestive heart failure unspecified. So we do have default codes that we run to when we don't have the documentation to be more specific. So in this case, I-69.30. And this is unspecified sequela of a cerebral infarction. This is basically saying that the sequela effect of the stroke, it's unspecified. I know that the doctor or the clinician did not specify the sequela effect. They just said that it is one. So if you don't know what the defect is or the deficit is, you don't know if it's memory loss, you don't know if it's problem swallowing, you don't know if it's probably difficulty talking. If you don't know all of these, then run to your default code. Use I-69.30. And it's unspecified sequela of cerebral infarction. And if you look underneath the code I-63.0, it'll say sequela of stroke, NOS. And we know NOS is not otherwise specified. So again, Z8673. That's personal history of transient ischemic attack or TIA, or personal history of a cerebral infarction without residual deficits. That's what that code is for. Same as personal history of a stroke. If a person has a TIA or they had a stroke and there's nothing else wrong with them, then you would look to use the history of code. Also pay attention to your excludes 1 and excludes 2. If you see excludes 1 underneath that code, That means that you cannot code that primary code. And whatever it says excludes one, you cannot code those codes together. That means it's a direct conflict and you cannot code those codes together. It will be denied on a claim and you will not get your money for it because it's not valid. Okay, so if you look under Z86.73, you will also see under the excludes one, which is Z87.820, and that's personal history of a traumatic brain injury. The reason these two codes conflict is because you can't use Z8673 and Z87820 together. You cannot. The reason because Z8673, that's a personal history of a stroke. I mean, you had a stroke, there's nothing wrong with you, but you have a history of it, so we'll use that code. However, if a person has a personal history of a traumatic brain injury, that conflicts with the history of the stroke. We know that the history of the stroke means you had a stroke. There's nothing wrong with you, then that's why we're using a code. But if you had some type of brain injury due to something else other than a stroke, then you will use this personal history of traumatic brain injury code. And you cannot code those together. Because we know one code is you got personal history of a stroke. The other code is personal history of a brain injury. So this means that this brain injury is something caused other than by the stroke. So it's a direct conflict and you cannot code them together. So thank you so much for joining me in the most frequently coded diagnosis in a risk adjustment model. Thank you so much for joining. Don't forget to like, don't forget to comment, and don't forget to share. The Coding Coach, MJ the Coding Coach. Thank you so much for joining me today.